All right, so let's review one of the most common injuries to the pediatric elbow, the nursemaid's elbow, also known as a radial head subluxation. This is an injury that parents around the world have caused to their kids basically by hyperextending and pulling at their child's wrist, either because they're pulling them up from the ground by the hand, swinging them around over their heads in a playful manner, and basically causing a tear of the annular ligament. The annular ligament is at the radial neck and basically holds the radial head into that elbow. That tear comes from that hyperextension and then kind of blocks out the radial head, and it's a dislocation of the radial head out of the elbow. Typically, you're going to have a patient that's going to be anywhere from 1 to 3 years old, sometimes a little bit older. It is more common in girls than in boys, but this is something that you will see if you are working in a pediatric office, urgent care, emergency department. Very, very common. Classically, your patient will be sitting there holding their elbow in the flexed position, sometimes holding their wrist against their body, because any supination and pronation of that wrist is going to cause pain at that radial head. They'll have some point tenderness at the radial head, but shouldn't have any tenderness anywhere else on that elbow. They'll sometimes complain of pain at the wrist or the forearm, but you want to have a high suspicion if you see them just sitting here like that and refusing to use that elbow. One thing you want to think about before you kind of just going into reducing these, because the reduction is straightforward and you do not need to do radiographs prior to that, is to make sure there's no underlying like elbow fracture, right? So if you have tenderness palpation at the posterior elbow, the medial elbow, there's a lot of swelling, you may have some injury that's greater than just a nursemaid's elbow. In that case, you want to get an x-ray first before you start manipulating it, because it's not going to respond to a reduction for a nursemaid's elbow. We're going to go over two techniques, the supination technique and the hyperpronation technique. They're both equally efficacious. I personally like the supination technique a little bit better because it's easier for me, but some practitioners actually like hyperpronation. They feel like it's less stress and less painful on the patient. Either one works well, so we'll kind of review them both now. So the first technique I want to review is the supination flexion technique. This is my go-to because I have a lot of comfort. It's the one I've always been taught and the one that for me is personally easiest to remember. Basically, what you're going to do is have your patient sit in their parent's lap. Their parents will then give them some comfort as well as just support them while you're doing the reduction. I'll take my non-dominant hand and just place it underneath their elbow, their flexed elbow, and take my thumb and just palpate that radial head where the injury is. With my dominant hand, I'm going to grab onto their hand and wrist, and you're going to go through this motion of basically supination, extension, followed by flexion. So as you extend, you're going to supinate, 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 extend, keeping your thumb on that radial head so you can feel it pop when it goes back in. And then once you're completely extended and supinated, you then flex upward. With that movement, typically you'll feel that kind of pop as the radial head goes back in, and that's just your cue. It's like, okay, you're done. You've reduced that elbow. What I'll do then is just leave the patient with their parents, come back in 10 minutes, and see if I was successful. If they're using that elbow, if they're no longer having any pain and they're moving it freely, you've been successful and you can basically discharge them to go home. If you haven't, you want to think, well, maybe you did not reduce it and you can try another technique, or you also want to think about, is there any underlying injury, fracture that you need to kind of go further in terms of your workup? For the second technique, the hyperpronation technique, you're going to basically do the same setup. Have the patient sit in their parent's lap so they can support it. Grab their flexed elbow with your non-dominant hand with your thumb on the radial head. And then the other one, you're grasping again that hand and that wrist. Some people will extend and hyperpronate. Other people will flex and hyperpronate. But it's basically a movement of keeping them here and doing that hyperpronation. I'll typically keep them flexed and hyperpronate, up and flex. And you can do that relatively quickly. And again, you should feel that pop back in with your thumb on that non-dominant hand. Once you've done that, again, you just leave them, come back in 10 minutes, and reevaluate them. If they're using it, they're good to go, and you can send them home. Both of these techniques are relatively straightforward. I think the key is to just go ahead and do it, be comfortable with them, and then reevaluate. If there's anything that's off, then think, is there something else? Do I need to do x-rays or not?